Return to play after anterior cruciate ligament reconstructions. When and what tests to do? Safe or sorry? This is the status of where we are in 2016. I'm Mary Lloyd, Ireland. That's my website if you're interested in this or other presentations or updates. I'm an orthopedic surgeon, work at the University of Kentucky, Department of Orthopaedic Surgery and Sports Medicine. Disclaimer side, I nor any family member have any disclosures. The objectives of this presentation are to understand the tests and functional assessment done prior to return to play, communicate with rehab team to develop return to play protocols, look at evidenced and develop evidence-based functional assessment tests, ask questions. Think about it. The stupidest question is the one that is never asked. So ask questions, communicate with your rehab team and the patients and the parents and the coaches. The different sections are introduction, functional assessment, sex differences, prevention, and conclusions. What are we afraid of as orthopedic surgeons? Why are we afraid to let an individual go back when they tell us they're ready to go back or at a set date? We're afraid that they may re-tear their graft. We're afraid as an orthopedic surgeon and team physician we may look bad because the athlete is not performing well. The surgeon looks bad. They might injure something else. Or longer term, and probably more importantly, are we afraid that they may develop osteoarthritis? Well, are they going to get it anyway? Or are they accelerating the development of osteoarthritis by tearing their ACL, having a reconstruction, and then going back and playing sports full go, no limits, no follow-up? Or do we want to avoid an angry athlete, parent, or coach and delay the athlete going back to play? From the athlete side, there's also a fear factor and a confidence factor. Are they ready to go back? Are they afraid they're going to get hurt? And until they develop that confidence and get over their fears, most likely they will hurt something. Usually it takes another couple of months for them to develop their confidence, agility skills, and be fully ready to play. Orthopedic surgeons can stabilize the knee, but we cannot restore it to its pre-injury state. This mosaic of the knee will never return after you tear your ACL. The timing of return to play, we have to rethink biology of biologic healing, and this is variable due to multiple factors. Development of osteoarthritis. In a Swedish ACL registry, where all ACLs are registered in the country of Sweden. This is a female soccer study. 84 female soccer players with ACL reconstructions, 12-year follow-up. 42% had symptomatic knee osteoarthritis. 75% had symptoms that affected their quality of life. Think about that, 75% symptoms following their ACL reconstructions, 12-year out, that affected their quality of life. And looking at another group compared with those who had not had ACL reconstructions but tore their ACLs, there was no difference in osteoarthritis if they underwent an ACL compared to those who had not undergone an ACL. Very eye-opening information and data from a registry in Sweden. We need to communicate this with our players and not cavalierly say, sure, you'll be back to full go, no problems, don't have to worry about anything. They have to worry about long-term osteoarthritis, but a 15-year-old soccer player isn't concerned about that at all. Their parents may be. And we, as orthopedic surgeon and healthcare providers, should also be worried about the long-term results, outcomes, quality of life that are established, and whether these individuals develop osteoarthritis. In this study, is ACL reconstruction effective in preventing secondary meniscal tears and osteoarthritis, by Sanders. Significant findings: non-op more likely to develop meniscus tears, OA, and undergo total knee replacement compared to those who had an early ACL reconstruction. If ACL reconstruction was delayed, they were more likely to develop meniscal tears and OA compared to early ACL reconstructions. So in this series, earlier intervention, less meniscal tears, less likelihood of a meniscus resection, and they did better, developing less osteoarthritis. I think these are studies that we need to continue to do and do these prospectively. In this same study, the purpose of this was to evaluate protective benefit of ACL reconstructions and evaluate factors predictive of long-term sequelae. The mean follow-up was 13.7 years, range of 2 months to 25 years. It says 964 patients, new onset of ACL tears, compared to sex-matched cohort without ACL tears. 364 were non-op, 509 had ACL reconstructions, 91 were delayed. Level 3 level of evidence. The results: age greater than 21 at the time of injury, articular cartilage damage, medial or lateral meniscus tears, predicted osteoarthritis after ACL reconstruction. Makes sense, and the literature supports it. Conclusions of the study: patients undergoing ACL reconstruction had significantly lower risk of meniscal tears, symptomatic OA, and total knee replacement compared to non-op patients. Early ACL reconstruction significantly reduces the risk of subsequent meniscus tears and OA compared to delayed ACL reconstructions. This is a patient of mine who I was seeing for patellofemoral osteoarthritis. X-rays on the right were the knee that I was taking care of. You can see in the bottom how much patellofemoral osteoarthritis she has. She had been playing basketball since she was a young child, played at the University of Kentucky, and was playing professional basketball when she tore her ACL on the X-ray on the left. So here's her newly injured ACL side. You can see maybe a little bit of spurring here. Her patella looked fine. She underwent an allograft ACL reconstruction, not by me, but I saw her in follow-up. So she'd been playing basketball for 36 years. Previously, her ACL side was not symptomatic, had arthritis of her patellofemoral articulation on the opposite side. 3.5 years after her ACL reconstruction, she has tri-compartment osteoarthritis, and she hurts. One can look at the tunnels and say, well, it's a vertical tunnel. But bottom line is she most likely had loaded her knee repetitively, and perhaps had we gotten some images that would have shown bone edema, like a bone scan, other studies, we would have known that she had pre-existing propensity for osteoarthritis, most likely because of how much basketball she'd played and the loading that she put on her knee for 30 years. You can see her cystic change here, osteophytes, and basically tri-compartment osteoarthritis. Now she hurts. She's 40 years old. A concept of pack years, as in smoking, the additive effect of years participating in basketball. So I think we need to understand a concept of pack years of smoking on the lungs. Well, it's like pack years of activities on the knees. The more one sport you play, probably the worse it is, because that's a repetitive thing, particularly on the knees in basketball. And she perhaps had too many pack years of basketball even before she tore her ACL. The goal: return to play after ACL reconstructions. You have to know your return to play team. You have to understand the tests that assess strength and movement patterns after ACL reconstruction. The test you should be shown that are performed in functional assessments to determine readiness to return to play, understand what these tests are measuring, review mechanisms of injury, and how this relates to safe return to play and prevention programs. It's all about avoiding the position of no return. Successful ACL reconstructions, short term, safer, not faster return to play. Long-term goal, prevention of osteoarthritis. The average return to play after ACL reconstructions is 6 months. It's variable with each individual, patient, age, and sport. There are many factors the athlete must overcome prior to return. Fear of re-injury, reestablishing strength, balance, hip, and knee control, developing that agility, ability to move your feet, developing confidence. Most athletes are returning to exactly the same sport, how they tore their ACL in a non-contact mechanism, so they must overcome this fear of re-injury and develop their confidence. This is an important factor that you can ask the patient if they're confident, ask them if they're fearful of re-injury, and if the answers are yes, then keep them out for a longer period of time. Don't let them back in the game until they're confident and can do full practices. Appropriate use criteria, or AUCs, have been adopted by our Academy of Orthopedic Surgeons. This is one with 2 new ACL AUC checklists are now available. Also, the full scope of prevention and management of ACL injury has been covered. So in the patient's chart, we should have a patient return to play checklist after an ACL reconstruction. Highlighted are the things that we as orthopedic surgeon and our ACL rehab team, athletic trainers, physical therapists, need to come together to decide what are these check boxes. When can we check they're ready to return? Functional return of patient's core, hip, quadriceps, hamstring strength has occurred. When do we check that box? What tests do they need to pass? We have an idea at the University of Kentucky. We should work together and do more studies. This return to play test is determined by clinician discretion, can be measured by a variety of methods, leaves the door wide open. The second thing is patient's functional balance is restored. There are certain balance boards, other measuring devices. You can have somebody just close their eyes, see how well their balance is. So this is a test that you can come up with your therapist to have that answered. That's probably easier to answer, balance restored, than the return of core, hip, quad, hamstring. We all are working together on what we think is the best checklist for that functional assessment. The quality and variability of physical therapy protocols for ACL reconstruction in the U.S. A review was done of this. The conclusions were, in the U.S., there are no standardized or evidence-based protocols. This was based on a review of online ACL reconstruction protocols by the Rush Medical Center Group. 155 academic orthopedic programs viewed their online information. 33 had online post-ACL reconstruction protocols. There was substantial variability in the types of exercises and the time to return to play, and the protocols were not supported by evidence-based practices. By standardizing protocols, we might lead to improved outcomes. So we need more evidence-based practices to determine if our outcomes are acceptable and if patient satisfaction is acceptable. The functional assessment tests that are done are a basic versus an advanced. This is like a level 1 versus level 2. At the University of Kentucky, these are the things that we do. We're assessing strength with leg press, balance with a couple of different ways, timed agilities, sport-specific dryland testing to show the athlete level of readiness to return to the field of competition. When you do certain sport-based movement patterns, the athlete can figure out they're not ready to go back, whether it's dribbling with a soccer ball, changing directions, landing from jumping, such as in basketball. And I think it's also important to have the coach or the parents watch them do some of these activities, and they can easily see that they can't really do this in a fast speed game situation yet. They need to continue to work on confidence and improvement. What are the tests done to determine readiness for return to play? The level 1 tests are gait assessment, single leg step and hold times 10, Y balance, strength testing, knee extension isometric 90 degrees to 0, hip abduction and seated external rotation, one leg at bridge to fatigue, and plank. The grading scale, 3 is normal, 2 equals minimal deviation, 1 equals moderate deviation, 0 equals marked deviation. The assessment is done. They have to pass all phases, and if they didn't pass the phases, it's due to one of the deficiencies such as pain, decreased eccentric knee control, neuromuscular strength, proximal strength. Level 2 functional assessment return to play, hop testing in inches, vertical hop, single leg, broad jump, timed 6 millimeter hop, single leg triple jump, single leg crossover jump, hop testing quality assessment. The grading is similar, good control, sufficient knee flexion to avoid valgus. So I have to land in a safe position, good hip over knee over ankle position, and no valgus at the knee or internal rotation adduction of the hip. So you can see these are more violent movement patterns, more vigorous movement patterns, and are getting close to what they would do at the time of return to their sport. So level to clearance for sports, drop off box to squat jump, plyometrics, repeat this 3 to 5 times. It's graded on 0 to 3. The 3 grade are symmetrical landing on both feet, symmetrical hip and knee flexion. Greater hip and knee flexion, the better, the more control. Landing is soft, avoid valgus at the knee, and landing is balance. If the landing's balanced and soft and symmetrical, then they're on their way back to sports. These are the sheets that we use at University of Kentucky. This is given back to the clinician by the physical therapist or athletic trainer, and this gives us information. Passes all phase, did not pass all phases because of the following, and this will give us a percentage or a number that we can discuss with the patient, parents, and the coaches of what they need to do to pass. And then this would be repeated in another month. Functional assessment level 2, you can see is a little bit more vigorous, more movement patterns, closer to return to sport. And again, it gives a number, hop testing, hop quality assessment, drop-off box. So there are some numbers that are objectives, but some of these other ones, the hop testing quality assessment, are more subjective and are graded by the physical therapist or the athletic trainer. But again, giving the athlete a score, the total goal is a score of 14 out of 15. This is an example of an advanced functional assessment. I really like it when the therapist write the numbers down and we can get, again, numbers. So this is based on a 21% difference up at the top. Single leg long jump is 8%, single leg triple jump 11%. So this gives me information to show the patient, and they're usually not ready at a 20% difference. They should work more on these numbers. Single leg vertical jump. And we'll have them work on these and repeat the test in another month. The rest of this, single leg timed agilities, a little bit deficits. The sport-specific agility test, they have 3 trials. This is run and stop, cones, cut, so you can change these based on their sport. And the overall differences in this were 16%. So I really like it when I get an assessment from the physical therapist. So you have 13% deficit quality of movements, 11 overall. So the patient did really pretty well, but they had some things they needed to work on lateral direction changes and overall strength and power. And so this gives the athlete a game plan of when they can really get back on the field and gives them some specific things to work on. The athlete can tell when they're ready to go back. So some of these quality of movements and some of these changing of direction, that's a harder thing to get back, and so they know what they have to work on to be ready, and they will totally ace it the next time. So I'd repeat this in 2 to 4 weeks and see how they do. It's good to have the parents watching them when they're doing this because they can see that they're not ready to cut and be 100%. Thank you for your attention. This is a .com where there are more presentations. Protect our female athletes.